Good morning. In this section, I will be discussing prenatal screening and testing. One of the most important goals in doing genetic testing on a child with a serious genetic condition is to try and prevent it from happening again in this family. In addition, the prevention of serious genetic defects in general would be the ultimate goal in genetics. So why do we do prenatal screening? In a family who previously had a child or has currently a child with a genetic condition, they would only have the choice to not have more children if genetic testing was not available. Now we can give them a range of choices. This can assure them that they can go ahead with a pregnancy knowing that there is a method to prevent it from happening again. If they do fall pregnant and undergo testing, and then receiving a normal result, it reduces anxiety. I always say 9 months is a long time to wait to see if your baby is normal or not. We cannot at all guarantee a normal baby, but we can exclude the condition if we do prenatal testing and the results come back normal. If they do decide not to terminate the pregnancy, they can prepare themselves for the birth of the baby, and the management of the baby can be appropriately decided on. If a baby is born in a tertiary hospital, its chances is much better than a rural hospital. There is even cases where there is prenatal management for the fetus to reduce the risk of serious complications. Even fetal surgery is becoming more common. Unfortunately, a genetic defect cannot be cured, but the best possible management can be given. So when and why would we do prenatal screening and diagnosis? I think advanced maternal age is the most common indication for doing a prenatal test. In South Africa, we regard advanced maternal age as 35 years at the time of conception. It might differ in other countries and even go up to 40 years in some countries. This age was decided because the risk of losing a baby after amniocentesis is equal to the risk of having a baby with Down syndrome at 35 years of age. If a couple previously had a baby with a chromosome abnormality, or if one of the parents have a structural chromosome abnormality such as balanced translocation, there is a risk for an abnormal baby, and the parents might want to test and selectively terminate the pregnancy if the abnormality is predicted to be severe. If there is a family history of a certain condition which might be diagnosed or ruled out by DNA analysis or even biochemical analysis, this would be an indication for prenatal testing. For instance, if a mother has a brother with Duchenne muscular dystrophy and testing shows she is a carrier, she might want to test if she's expecting a baby boy. If there is no specific prenatal diagnosis, but you know the condition only happens in boys, it might be an option for the family to terminate all male pregnancies. You can just imagine how difficult this must be, as there is a 50% chance that the baby might be completely normal. This does not happen often, luckily, because we have testing for most of these conditions available. In the case of a neural tube defect, which is when the spine of the baby didn't close early in the pregnancy, substances in the maternal blood, amniotic fluid, and an ultrasound, also called a sonar, can pick this up now quite often, giving the parents the option to not continue with the pregnancy if they wish to. If the sonar or maternal blood suggests an abnormality, this can be confirmed with more invasive testing. So, also if there is any suspected abnormality in the fetus, this might prompt prenatal testing. I will now start with prenatal screening. Remember, this differs from testing, as it only gives a risk and is not confirmatory. Traditional screening was done on substances in the mother's blood and ultrasound to detect Down syndrome and other trisomies, that is trisomy 13 and 18. As it only determines a risk, all screening tests need confirmation with further testing before a final diagnosis can be made. The prenatal screening is either carried out in the first or the second trimester. The first trimester testing is done between 11 and 13 weeks gestation, and the second trimester from 15 to 20 weeks. The first test done in the first trimester will be to measure the skin fold thickness behind the back of the neck of the baby. This is called the nuchal translucency and basically measures subcutaneous edema or swelling behind the neck with an ultrasound. Trisomies such as trisomy 21, as well as other conditions such as Turner syndrome, congenital heart lesions, or metabolic abnormalities, can present with an increased nuchal translucency. Substances measured in the maternal blood or the serum in the first trimester is PAP-A, standing for pregnancy associated plasma protein A, which is decreased in most of the trisomies. Human chorionic gonadotropin, also called beta-ACG, is the hormone you test for to determine if you are pregnant or not. It has certain values at certain gestations, but it is increased in trisomy 21 and decreased in the other trisomies. As previously mentioned, the result only determines the risk, and the detection rate is only 84%, with a 5% false positive rate. You will remember Dr. Fick gave you lectures on this in the first genetic testing lecture. Going to the second trimester, an ultrasound and maternal serum screening can be performed. Maternal serum alpha fetoprotein levels can be determined. This is a substance secreted by the fetal liver and placenta and can diagnose when the abdominal wall is open or when there is an open neural tube defect, also called spina bifida, as you can see on the photo. If there is a spina bifida, the level will be very high. As mentioned with ultrasound, most of these defects can nowadays be detected. The alpha fetoprotein is lower if there is a trisomy, but we will never use this as the only level. It will be included in a test named the triple test. The triple test is used to detect a risk for Down syndrome, trisomy 13 or 18. It includes alpha fetoprotein, human chorionic gonadotropin, as well as unconjugated estriol. These levels, as well as the mother's age and the nuchal translucency, is inserted in a computer program which will calculate a risk. Here you can see the detection rate is only at 70%, with a false positive rate of 5%. The quadruple test is when you add a substance called inhibin A. It's again inserted into the computer program, and this increases the detection rate to 80%. Hereby the estimates for the different trisomies. I'm not going to expect you to know the detail of when the level is up or down. There is also other observations the gynecologist can see on ultrasound in the case of trisomy 21. You remember the nuchal translucency or the nuchal thickening. The ventricles in the brain might be slightly dilated. The head might have a more rounded shape called brachycephaly, or the nasal bridge might be low. The fifth finger might be incurving, called clinodactyly, or there might be a sandal toe or a sandal gap, where the space between the big toe and the second toe is larger than normal. This is all features we see in a newborn baby with Down syndrome. The bowels might have a bright pattern, or there might be a focus in the heart, or the kidney pelvis might be dilated. This is, however, non-specific, and a diagnosis can never be confirmed just on ultrasound finding. Again, I will not expect you to know the detail. To do cytogenetics on a sample, you will need to get DNA or a sample from the fetus, and invasive testing such as amniocentesis or chorionic villus sampling will be necessary. This will be done to confirm or exclude screening results, or if there is a specific cytogenetic defect in the family. Chorionic villus sampling is done at about 11 to 12 weeks gestation, and either through the cervix or through the abdomen of the mother. A needle is inserted under the guidance of ultrasound towards the placenta, called the chorionic villi. So, in the case of a chorionic sampling, a small piece of this placenta will be taken with a needle and a syringe. The sample consists of cytotrophoblast cells, which is the outer layer of the cell, and the extra-embryonic mesoderm, which is a part of the fetus. You don't need to know the embryonic detail. The risk for a mother to lose the baby due to a CVS is, however, around 1%. This is therefore very important that prospective parents should be informed about the risks when they do actually do a specific test. And they should get counseling regarding the risk of the procedures, and written consent should be taken. There's, however, problems in some cases where the interpretation might be very difficult, as there might be a case of chromosomal mycin, so that it can't be determined if the abnormality is in the fetus or only in the placenta. There's always a risk of maternal contamination when the result reflects the mother's status and not the baby. For instance, if the sample is from the uterine wall instead of the placenta. It's therefore important in all cases of a CVS to also send blood from the mother, especially if testing is performed for a single gene defect. Amniocentesis is done between 16 and 18 weeks gestation, where a needle is inserted through the mother's abdomen into the uterine cavity, aiming for a pool of amniotic fluid under ultrasound guidance. The fluid is largely derived from fetal urine and consist of skin and bladder wall cells. The risk for losing the baby is less than a CVS at about 0.5%. But nowadays we actually give a rather equal risk, as some of the babies that abort earlier would have aborted anyway without the procedure. The disadvantages of amniocentesis is, however, that the results takes longer, and as the procedure is done later, the mom would be much more advanced in the pregnancy, when she and the father might have to make the difficult choice to decide if they would continue with the pregnancy or not. As mentioned, mosaicism is always a concern, and there are methods how you can try to clarify it. First is to culture the cells, and if it's confined to the cytotrophoblast, it is less likely to be significant. Amniotic fluid samples will always be cultured in 2 flasks, or even more, and the analysis will thus be done on colonies of individual cells. If it's a true mosaicism, it will be present in all the flasks. If it's pseudomosaicism and present in only one colony, it's usually not clinically significant. Late in the pregnancy, thus after 18 weeks, when a defect is detected, or if an amniocentesis was unsuccessful, it might be necessary to do a chordocentesis, where a needle is inserted through the mother's abdomen into the umbilical cord and a blood sample is taken. This can enable DNA analysis, cytogenetics, and biochemical testing. The risk for a miscarriage is, however, 2%. The following tests can be done on prenatal tissue: your standard chromosome analysis, FISH or QF-PCR for your aneuploidy syndromes, chromosome microarray analysis, certain biochemical tests, or DNA tests for single gene disorders. This concludes the more traditional approaches. In the next lecture, I will discuss the new approaches as well as genetic counseling.